Madam, നമുക്ക് session start ചെയ്താലോ madam? Okay, madam.
It will be good if all the other sides can mute their microphones while she's teaching, so the audio is clear, please.
Screen share ചെയ്യാൻ പോണേ അഭിലാഷ്.
Madam, start ചെയ്യും madam, session start ചെയ്യും madam, problem ഇല്ല.
Start ചെയ്യട്ടെ?
Start ചെയ്യും madam. Hello.
കാണാമോ?
Madam, ഒരു മിനിറ്റ് മനുഷ്യ ഒന്ന് ഹോൾഡ് ചെയ്തോ. Madam കേൾക്കുന്നുണ്ട്. ആ പ്രസന്റേഷൻ സ്ലൈഡും കാണുന്നുണ്ട്.
കാണുന്നുണ്ടല്ലോ.
കാണുന്നുണ്ട്. Problem ഇല്ല. Okay, madam.
Okay. I hope I am clear and audible. Very good morning to everyone, and welcome to the CE teaching program, which is a very applaudable step from the government of Kerala. Let me thank everyone in the team, including Srihari and all the NHS team, Abhilash, the whole web team, Namrita, Vijay, PSL, Sunita ma'am, everybody for coordinating this and making this a reality. And let us go into the presentation right now. Oh, I don't know where my presentation went, sorry. Okay. So when we're going to start then? So applies to everything, including our sessions as well as every one of your encounters with your patients. And when you encounter patients, how do you begin? You begin with history, you go to physical examination, and then you do investigations. So if during any time of your clinical evaluation you find any point or any factor which is unexpected from your history, you go back to your history and cross-check. Same with physical examination. So everything is complementary, and that is how you arrive at a diagnosis and plan your management, right? So focus and informed history is a solid base to your clinical evaluation. And for a thorough history, you need to be well versed with symptomatology. So today's teaching is focused only on symptomatology of heart disease in children. So jumping straight into cardiac symptoms, so there are 6 classic cardiac symptoms, which are dyspnea on exertion, fatigue on exertion, angina or chest pain on exertion, syncope, palpitations, and cyanosis. When we talk about symptoms in children, we should also think about their age-specific equivalents. Other points to note in history while dealing with children with heart disease is possibility of recurrent lower respiratory infections as well as failure to thrive as a cardiac symptom. These could be due to underlying heart disease, especially large left right post-tricuspid shunts, that is PDA-AP window, but other causes need to be ruled out before attributing it to heart disease. So what are the implications of symptomatology? If the parents or the child thinks of who is to think about and rule out a heart disease, or every child whom we meet to rule out heart disease, always ask about which is the patient should be around. The two important points to note when we do symptomatology in cardiac disease is that, more so in this I will say, especially newborns and infants, not all cardiac symptoms might be suggestive of critical heart disease or heart disease at all. And not all critical heart disease or heart disease always present symptoms. So either ways, there might be symptoms, but it could not be it might be a very active underlying heart disease, but the patient could be asymptomatic. So these two can happen. So you have to keep this in mind. And most important, do not ignore any point in history. Sometimes you might know its importance only later in the course of your evaluation. So now we will discuss each of these symptoms in detail. Dyspnea. So So you know that the definition of dyspnea is an undue or unpleasant awareness of one's own breathing. You all are well versed with the definition of tachypnea, which is a respiratory rate more than normal for age. So dyspnea could be either respiratory or cardiac. And when you think about dyspnea from a cardiac point of view, it means that the patient will either have pulmonary venous hypertension or hypoxia. So these are the two underlying implications when you think about dyspnea as a presenting symptom in heart disease. Two terms which often come up while discussing dyspnea related to heart disease are orthopnea and PND. These are more important in older kids and adolescents. Orthopnea is dyspnea occurring within minutes of lying down. The mechanism is that the venous return increases from the lower limb veins and the diaphragm movement decreases, and this precipitates dyspnea. On the other hand, PND, the mechanism is different. It is again a classic feature of left ventricular failure, occurs after 2 to 3 hours of sleep, and this is also relieved in sitting position, but the mechanism is different from that of orthopnea. So the most commonly implicated mechanism for PND is the slow resorption of fluid from the extracellular compartment of the lower limbs into the intravascular compartment, resulting in increase in blood volume. Some other theories have also been proposed, which include depression of respiratory center during sleep, and also like when the patient goes into REM sleep, the sympathetic activity increases, which can increase in heart rate and cause worsening of heart failure. Also, transient nocturnal arrhythmias have been implicated in the mechanism of paroxysmal nocturnal dyspnea. So, we've already mentioned that from a cardiac point of view, it indicates dyspnea on exertion or at rest. That is full-fledged heart failure indicates either left heart failure, which is pulmonary venous hypertension, or cyanotic CHD. So what is the mechanism of dyspnea in a cyanotic CHD? So cyanotic CHD patients always have hypoxia. Some of them have acidosis, especially when the hypoxia is severe. Either of these can cause a stimulation of the respiratory center and cause tachypnea at rest. During exercise, the hypoxia worsens due to an increased right to left shunt due to systemic vasodilatation and increased heart rate and venous return. So that is the mechanism of dyspnea in cyanotic congenital heart disease. How about the mechanism in left heart failure? Actually, we'll go a little bit of deep into this because this is the basis of management of most of the heart diseases. Like your entire outcome will depend on how quickly you were able to identify heart failure and how quickly you were able to manage it. So you all know the definition of heart failure. Here, heart fails to pump blood at a rate commensurate with the requirements of the body or does so with an elevated filling pressure. So essentially the basic mechanism is that the filling pressure is increased. So what is the filling pressure? Filling of the heart occurs in diastolic. So filling pressure essentially means diastolic pressures. So the normal diastolic pressures or the end diastolic pressures of the right ventricle are somewhere between 2 to 6 millimeters of mercury, left ventricle somewhere between 7 to 11 millimeters of mercury. If you look at the mean pressures of the atria, it closely follows the ventricles. Like RA mean is somewhere between 2 to 4, LA mean 6 to 10. So the LA mean has some relation to the EDP, as you understand, and RA mean has some relation to the RV-EDP. This is because these chambers communicate with each other. And if you look at the pressures of the aorta and the left ventricle, the systolic pressures are equal. Similarly, on the right side, the systolic pressures of the pulmonary artery and the right ventricle are equal because they communicate in systole. So what happens in heart failure? We know that the heart is pumping at an elevated end diastolic pressure from some abnormality which is detectable or not, which is diagnosed or not. So as the end diastolic pressure increases, we know that the LA pressure follows the EDP. So the LA pressure increases. Where is the LA connected to? It is connected to the pulmonary veins. So the pressure inside the pulmonary veins increases. That is called pulmonary venous hypertension, which you see on chest X-ray as grades 1, 2, and 3. Grade 1 meaning interstitial 1 and 2, essentially interstitial edema of two stages, and third means frank alveolar edema or pulmonary edema. So this is heart failure. And how do you get hepatomegaly and elevated JVP in heart failure? That is also called backward failure. So you know that the pulmonary veins are connected to the lungs, and so is the pulmonary arteries. So the elevated pressure in the pulmonary veins get transmitted backwards into the pulmonary arteries into the right ventricle, and the effect is seen in the right atrium. And as the right atrium communicates with the superior vena cava and inferior vena cava, also the hepatic veins, you see it as an elevated JVP and hepatomegaly. So this is biventricular heart failure. And now, how does heart failure cause dyspnea? As you have pulmonary venous hypertension, that is transportation of fluid into the interstitium and then into the alveoli, an increased respiratory effort is needed to move the congested lungs for respiration. So that is how the patients have dyspnea. So another mechanism is that when there is interstitial fluid, the J receptors get stimulated and they stimulate the respiratory center. Also, an increased respiratory effort without proportionate lung expansion due to the congestion leads to intercostal and subcostal retraction. So that is the mechanism. So this you will all be aware about the grading of dyspnea. In older children and adults, it is the NYHA class. Class 1 is asymptomatic, or someone gets symptomatic only with more than ordinary activity. Class 2 is developing dyspnea with ordinary activity. Class 3 with less than ordinary activity. Almost any activity causes dyspnea. And class 4 is dyspnea at rest. But you know that this is not applicable to newborns and infants. So the grading of dyspnea in infants is based on the Rose classification, which is from the Canadian Pediatric Society. So here it is actually similar to the NYHA class only. Class 1 is again asymptomatic. Class 2 is mild tachypnea or diaphoresis with feeding in infants. And of course, dyspnea on exertion, as we already discussed in older children. Class 3 is marked tachypnea or diaphoresis with feeding in infants, and marked dyspnea on exertion in older children. So prolonged feeding time with growth failure can also be classified as class 3 Rose. Class 4 is retraction, grunting, diaphoresis at rest. So that is equivalent to NYHA class 4. So we'll go to the next cardiac symptom, which is fatigue. So fatigue or on exertion especially. So exertional fatigue denotes inadequate skeletal muscle perfusion during exercise, which is a feature of reduced cardiac output. So it can be an indicator of any heart disease, including heart failure or fixed RVOT obstructions, fixed LVOT obstructions. So these are the major cardiac diseases which can present as exertional fatigue. I would like to mention that the proper symptom of exertional fatigue can be present in mostly adolescents and older children, not in infants. You will get surrogate markers of this in infants. So feeding difficulty. So this is an age-specific variant of exertional dyspnea and fatigue in infants while sucking, as I just mentioned. So when we discuss about symptoms in pediatrics, the age-specific variants of the classic presentations of the classic symptoms are very important. So feeding difficulty is a classic presentation of heart failure in infants. So what happens here when the baby sucks at the nipple? The baby develops dyspnea and fatigue, and the baby rests after a small feed for a few minutes, and then the baby starts sucking again. So this is suck, rest, suck cycle, and this is one classic presentation of heart failure in infants. The heart failure could be due to any reason, including left to right shunts or incessant arrhythmia or L kappa. So while sucking, there will be dyspnea and forehead sweating. And another way of assessing this when you're in the clinic is asking about the feeding time. So sometimes the mother will only say that the baby takes like 1 hour to complete a feed or 1.5 hours to complete a feed. So prolonged feeding time also indicates feeding difficulty. Failure to thrive. So this is another important presentation of heart failure in children. The pathophysiology is that in CHF there is feeding difficulty and decreased calorie intake. Also there is increased catabolism at the same time, and these patients also develop recurrent respiratory infections. With each infection the intake is less and the demand is more. So all of these contribute to this pathology. Again, another important factor how CHF leads to failure to thrive is that you know that there is systemic venous congestion in heart failure. This causes portal venous congestion, which causes edema in the mucosa of the gastrointestinal tract. This can cause anorexia and decreased absorption from the gastrointestinal tract, which contributes to failure to thrive. Also, failure to thrive could be a part of a syndrome which the patient is having along with the heart disease like DiGeorge or rubella syndrome. Also, you have to keep in mind that failure to thrive leads to low immunity, and this leads to recurrent infection, and this becomes a vicious cycle. So let us look into recurrent lower respiratory infections. So what is the definition of recurrent lower respiratory infection? It is defined as more than 4 to 6 episodes of lower respiratory tract infections in a year. Mind you, lower respiratory infections or 2 episodes requiring hospitalization and or IV antibiotics. So when you take the history, you have to be very sure, like, where the baby got admitted, whether the admission was really necessary or not also, not that blindly follow that, okay, the baby is getting admitted every time. I would say that this is commonly seen in post-recuspit shunts, as I mentioned, VSD, PDA, AP window, not in ASD generally, because these are the shunts which cause left ventricular failure and pulmonary venous congestion, especially in infants. So we know that the pathophysiology of recurrent respiratory infection. We already discussed that the poor weight gain leads to poor immunity and predisposes to infection. So other mechanisms are that the interstitial edema and the pulmonary venodilatation, which is part of the heart failure, causes compression of the bronchioles and retention of secretions. So the pulmonary venous condition can cause anastomotic channels between veins, pulmonary veins and the bronchial veins, which leads to bronchial mucosal congestion. So this can cause or predispose to recurrent infections. There are some other mechanisms like goblet cell hypertrophy, etc., which leads to impaired mucociliary clearance, which predisposes to recurrent infections. Another factor is that when there is a large left to right shunt, the pulmonary arteries get enlarged, and the left pulmonary artery in close proximity to the left bronchus may cause compression of the bronchus, resulting in retention of secretions and impaired clearance. So this can also predispose to recurrent lower respiratory infection. And now coming to 3 other symptoms, angina, syncope and palpitations. There are some stuff which are in common to 3 symptoms, which is that I would say that the 3 steps to assess chest pain, syncope or palpitations is in a clinic is history, history and history. You know why? Because we all know that these are common presenting symptoms in the clinic. Majority might not have underlying structural or other heart disease, but when present, it could be a fatal disease also. Hence, we need to rule out heart disease as a cause. How do we do it? History is the easiest way to do it. History and physical examination should tell you who needs further workup, because if you start investigating all of these patients, most of them will end up getting second and third line workups, the availability of which is an issue, the cost of which is an issue. So I would again say that only a thorough history and physical examination will help decide who needs further workup among the patients presenting with these symptoms. So we'll look at chest pain in a little bit detail. As I already mentioned, chest pain in children is unlikely to be cardiac in origin, but in all these patients, you should ask and rule out certain history, or you should rule out certain diseases. So exertional chest pain in children can be due to coronary obstruction in Kawasaki disease or Takayasu arteritis. The patient can have a myocardial oxygen supply demand mismatch, like what happens in right or left ventricular hypertrophy. It could happen in patients with pulmonary hypertension. It could happen in patients with any form of left or right ventricular outflow tract obstruction. The third anomaly that you should rule out is an abnormal origin of the coronary artery, more commonly an interarterial course where the anomalous coronary artery courses between the aorta and pulmonary artery, where it gets compressed between the two. Or sometimes there is what is called the intramural course, where the origin is within the tissues and it is stretched and angulated, and that can cause symptoms during exertion. And you all are well versed with L kappa, which is anomalous origin of the left coronary artery from pulmonary artery. These babies can present with angina equivalence. Other causes of cardiac pain, chest pain in children can be pericarditis, and mitral valve prolapse has also been implicated in chest pain, but it's just a theory and not a proven proposition. So, anomalous surgeon of left coronary artery from the pulmonary artery, very rare, but if you identify these patients correctly at the right time, we can save them from dying. So, these patients present with either features of heart failure in infancy. Some of them actually can improve as collaterals develop, but most of them don't improve. And older children who escape the features in infancy or develop collaterals and their symptoms subside can present later with angina, dyspnea, or syncope on exertion. So Alcapa has actually the dubious honor of present of the heart disease, which can present with angina attacks or similar episodes at the earliest stage. So Alcapa generally becomes symptomatic around 6 to 10 weeks of age when the PVR falls. And what happens is that while feeding, these kids can get paroxysmal attacks of discomfort like angina like discomfort. So the or the infants manifest it by expiratory grunts, followed by sometimes marked pallor and cold sweat, some appearance resembling like a shock, or sometimes even loss of consciousness. So, any patient presenting with heart failure or symptoms typical of this, like paroxysmal attacks of irritability or feeding difficulty, and sometimes even loss of consciousness with that. So you have to suspect L kappa, and I would say ECG is very helpful in these situations to pick that up clinically. So here's a checklist for your patients presenting with chest pain. You always have to ask about the duration of chest pain, because some of them say that they always have chest pain or chest pain lasts for hours, which is unlikely to be cardiac in origin. Exertional, which lasts for a few minutes and gets relieved by rest, could be cardiac. You have to ask about precipitating relieving factors. Particularly, you have to ask about any specific food relation, or whether it is related to a fall or injury, so that you can attribute it to a non-cardiac cause. You have to ask about associated symptoms. This is very important. If chest pain is associated with either sweating or syncope or palpitations, it could be a cardiac cause. You have to definitely ask and rule out history suggestive of Kawasaki, whether there is a clear-cut history of admission for Kawasaki, or whether there was history of a prolonged fever with rash or peeling, which could suggest Kawasaki, which was undiagnosed. You have to ask about prolonged fever with joint pains, or you have to, definitely see whether the patient is already a known Takayasu patient presenting with chest pain. And in every patient in presenting with chest pain, you have to ask about family history of young myocardial infarctions, like less than 40 years of age. You have to ask about history of sudden cardiac deaths in the family, especially in the end. These patients will need evaluation for lifestyle diseases as well as sometimes even thrombophilias, depending on the family history. And always check forelimb blood pressure, because sometimes patients cannot complain about hypertension. They might feel some discomfort in the chest when they increase blood pressure, and they might come and say that I have chest pain. So unless you check the blood pressure in all patients presenting to you, you will miss hypertension in children. So we'll move to the other symptom, which is syncope. So how do you define syncope? Syncope is transient loss of consciousness due to a decreased cerebral perfusion with inability to maintain postural tone, and which has spontaneous recovery. So this definition excludes seizures, coma, shock, or other states of altered consciousness. So the points are transient loss of consciousness, inability to maintain postural tone, and spontaneous recovery. Sometimes the patient actually gets a feeling that he will fall down, but he sits or lies down before he actually falls down or loses consciousness. That is called pre-syncope. So both are could be cardiac in origin, but the commonest cause of syncope that you will see in the clinic is vasovagal or it is also called neurocardiogenic syncope. It sometimes could be due to postural hypertension, or it could be due to some other syndrome like postural orthostatic tachycardia syndrome. So these are both changes in heart rate and blood pressure which are poorly tolerated when the patient suddenly gets up from a lying down or a sitting position. Also, syncope could be a cardiac symptom. And in any patient presenting with a history which is suggestive of a syncope or pre-syncope, you have to rule out neurological causes like seizure, TIA, migraines. That is in older children and adolescents. So, vasovagal syncope history is the most important point in ruling out whether the syncope is vasovagal or not. So, there are a lot of predisposing factors very typical of a patient who will be presenting with vasovagal syncope. So, these are the common ones. Dehydration. Most of them will come with telling you that they got up a syncope immediately after waking up from sleep. So sleep, what happens is like for 12 hours your body is not hydrated. So you're anyway predisposed at that time. And the second common situation is emotional stress or anxiety or fear, pain. Sometimes even hunger can precipitate. People who use alcohol or drugs, they are predisposed to get vasovagal. So another very particular history is that they were standing in a crowd, either at a funeral or in the church, where the oxygen supply is less, I would say, because there is more carbon dioxide around. So that is another common situation. And then another common history is that children standing in school assembly for a long time. So standing for long, especially in the sun, precipitates vasovagal. And hyperventilation can precipitate vasovagal, and sometimes it is associated even with coughing or urination. So this is micturition syncope, or sometimes some people have carotid sinus hypersensitivity, like turning the neck or wearing a tight collar can even present with vasovagal. So these are the common situations where patients can present with vasovagal, and history is your most important point or weapon in finding out whether the syncope is vasovagal or not. So syncope is a cardiac symptom. It could be either exertional or at rest. Exertional syncope is a classic presentation of heart disease with left ventricular outflow tract obstruction, like aortic stenosis, which could be valvar, subvalvar, or supravalvar. Right ventricular obstruction, again pulmonary stenosis, either valvar, subvalvar, supravalvar. Even pulmonary hypertension patients can present with syncope as a symptom. So how does exertional syncope happen in cardiac disease? Here, the heart is unable to increase its cardiac output in the face of exercise-induced peripheral vasodilatation because there is an obstruction. So you need more cardiac output, but the heart can't give it because of the obstruction. So then the patient experiences syncope. And stimulation of mechanoreceptors in LV is also implicated. And sometimes, these obstructive heart disease patients can have exercise-induced arrhythmias, which could also predispose to syncope. How about syncope at rest? So positional syncope can occur with diseases like LA myxoma, patient changes position and the myxoma comes and falls into the mitral valve and obstructs mitral inflow or inflow to the left ventricle, and it can cause syncope. And syncope in complete heart block or any other profound bradycardia is present with syncope at rest. You need not have exertion for that. It can happen at rest also. It is called Stokes-Adams attack. So, one of the commonest difficulties when we face these problems is deciding whether it was actually a syncope or not. So here are 4 questions which will help you finalize whether, okay, this is a syncope, this is not a syncope. 1, was loss of consciousness complete? 2, was loss of consciousness with rapid onset and short duration? 3, was recovery spontaneous, complete, and without any sequelae? And 4, was postural tone lost? So if the answers to these questions are positive, the episode has a high likelihood of being a syncope. So again, a checklist for syncope, you have to ask about duration. So generally cardiac syncope less than 2 minutes. If it lasts for minutes and hours, it is unlikely to be cardiac. You have to ask about the post-event phase, as this is the strongest differentiating factor from seizure. So there is no post-syncope phase like a post-ictal phase. You have to ask about precipitating relieving factors. That is the only way to find out whether it was a vasovagal syncope from history. And you have to definitely ask about family history of sudden cardiac death or unexpected deaths in the young or unexplained fainting spells. So these could be pointed towards genetic arrhythmia syndromes like long QT syndrome, Brugada, etc. And you definitely have to ask for a history of medications or drugs, because many of the QT prolonging drugs, etc., can cause arrhythmia and syncope. 2 commonly used drugs like diuretics, vasodilators can predispose these patients to syncope, more so if their fluid intake is inadequate. So we'll go to the next symptom, which is palpitations. So you all know that palpitations is unpleasant awareness of one's own heartbeat. It could be exertional at rest. arrest, or sometimes there are paroxysmal palpitations. So in small children, parents may notice increased precordial activity or neck pulsations, and sometimes children may describe it as chest pain also. So whenever you hear chest pain, you have to specifically ask more, like a little bigger kids can sometimes tell you that, when you ask, when you give them the option that, is it something like tuck, 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 they might say, yes, it is not chest pain, but it's feeling really some abnormality, which they don't know how to describe. So the symptom, it's not like in adults, it is very difficult sometimes to elicit a proper history in kids. So, exertional palpitations can be due to any of the volume overload diseases, which is atrial septal defect or mitral regurgitation, aortic regurgitation. Palpitation at rest may be due to volume overload lesions or due to an arrhythmia. Paroxysmal palpitations, which means there is abrupt onset and offset, are always abnormal and is likely, and the patient likely has an underlying arrhythmia. So what happens here is the maximal heart rate occurs in 1 beat's time. There is no warm up, warm or cool down phenomenon like slow increase in heart rate, which you will see in sinus tachycardia, or rarely some other arrhythmias can also present like that. But then paroxysmal palpitations are more abrupt onset and offset, mostly likely due to underlying arrhythmia. And many of these patients might have polyuria during the palpitation. And if you are lucky, you might get the history that a vagotonic maneuver like straining at stool, or blowing against, like you give something to sip with a straw and ask them to blow against it, that will terminate the arrhythmia. So these are vagotonic maneuvers which can which can terminate the arrhythmia. So checklist for palpitations, again you have to ask about duration and frequency. Older kids might be able to tell you whether it is fast or slow. You definitely have to ask about precipitating relieving factors, whether it is at exertion or at rest. And associated symptoms, if palpitation is associated with syncope, again it is a red flag sign. You have to completely evaluate the patient for major heart disease or underlying significant arrhythmias. And you have to definitely ask about, again, family history of unexpected deaths or unexplained fainting spells, because this could be another way how a genetic arrhythmia syndrome presents. Again, medication, drugs which can cause palpitations, and hypertension can also present with palpitations, so you have to check the forelimb blood pressure. And what I would say is, when you decide about workup, if the frequency of palpitations is very infrequent, then the best way to say whether there is actually any abnormality happening or not is asking the patient to go for an event ECG, like, to get an ECG when they actually have the symptoms, look into that ECG. And if the ECG is absolutely normal at that time, then, you have ruled out significant heart disease. Holter monitoring will help only if the symptoms are frequent, depending on what sort of Holter monitor you have. If you have a 2-week Holter, then if the symptom occurs once in 2 weeks also, it could help you. But if you only have a 24-hour Holter or a 48-hour Holter, you need to have very frequent symptoms to identify the arrhythmia on the Holter. All right, so now we will discuss cyanosis, which is another very important symptom of heart disease in children. So again, you are well versed with the definition, which is bluish discoloration of skin and mucous membranes due to increased concentration of reduced hemoglobin, more than 5 gram percentage. So the causes could be anywhere from central nervous system, musculoskeletal system, airways, alveolar capillary membrane, hemoglobin abnormalities, and cardiac disease. So cyanosis, central versus peripheral. So peripheral cyanosis, that the extremities are cold, and cardiac versus respiratory. An important thing to keep in mind is peaceful cyanosis is mostly cardiac. Respiratory distress along with cyanosis generally implies a lung cause, not always though. So now, how do we evaluate the cyanotic baby? One, you have to confirm whether the baby is cyanosed or not. How do you do that? You can use SpO2 to confirm. Two, you have to answer the question whether it is central or peripheral. If you doubt that it could be peripheral cyanosis, keep the baby warm for some time and then you check again. If it is peripheral, it will get relieved. Third is a difficult question. Is the cyanosis cardiac or respiratory? So generally, as I said, if there is associated respiratory distress, it could be respiratory. And then you can see the response to oxygen, which you all know, the hyperoxia test in newborns. And sometimes ABG can give you some clues. The X-ray and ECG can give you some clues regarding underlying heart disease when a baby presents with cyanosis. So we'll now look into cyanotic spells. So how do we define cyanotic spells? Cyanotic spells are progressive increase in the rate and depth of respiration, which culminates in paroxysmal hyperpnea, deepening cyanosis, limpness, sometimes syncope, occasionally in convulsions, CVA, and even death. So that is the definition of cyanotic spells. So the commonest age at with congenital cyanotic heart disease with decreased pulmonary blood flow present with cyanotic spells are between 2 months and 2 years. The peak incidence is between 2 to 6 months. You should note that cyanosis on crying is not really a spell, but crying or exercise can precipitate or trigger a spell. So what is the mechanism? So when the baby has a bowel movement or when the baby cries or on feeding, the sympathetic activity increases. So this results in increase in heart rate and cardiac output. The sympathetic stimulation can cause infundibular contraction, especially in tetralogy. And what happens as a result of all these is that the increase in heart rate and cardiac output causes increased venous return to the heart. And when you especially combine it with an increased infundibular stenosis or contraction, the right to left shunt increases. So that causes worsening hypoxia. So when the PO2 decreases and when the acidosis develops, the respiratory center gets stimulated and it makes the baby to breathe more rapid and deeply, and then this ends up in a vicious cycle because hyperpnea will cause further increase in heart rate and cardiac output. So this is the mechanism of a cyanotic spell. So next symptom which you could come across in cyanotic congenital heart disease is in especially in older children is squatting for relief of dyspnea. Some of them when they grow into adolescents or adults, they learn to restrict activity to avoid this. So squatting is a typical squatting for relief of dyspnea is a typical feature of top leg physiology. There are many other squatting equivalent positions also, like sitting with legs drawn underneath, legs crossed while standing, or a mother holding the baby with knees drawn towards the chin. And how the squatting relieves dyspnea in tetralogy like physiology, there are 4 or 5 mechanisms. The most important them are that when you sit in a squatting position, your femoral arteries get kinked. Femoral arteries get kinked, and that helps in increasing the SVR, that is the systemic vascular resistance. So the right to left shunt decreases. 2, the femoral veins get compressed, so the venous return from the lower limb is decreased, so the less desaturated blood reaches the heart. Also, as you compress the abdomen, more oxygenated mesenteric venous blood returns to the heart. So all these help how to relieve dyspnea in a cyanotic congenital heart disease while squatting. And I would also like to mention about some special situations regarding cyanosis, differential cyanosis, which is cyanosis more in the lower limbs, often with clubbing also. It is a classic feature of PDA with Eisenmenger, that is PDA where the right pulmonary vascular resistance is so high that it has resulted in right to left shunting, and it could also be seen in persistent pulmonary hypertension in the newborn where the PDA shunts right to left. Reverse differential cyanosis is cyanosis more in the upper limbs. It is a classic presentation or a classic feature of TGA with coaptation and PDA. And there is also some situation where the heart is apparently normal with cyanosis where the problem lies outside the heart, like in a pulmonary AV fistula or a systemic venous anomaly like IVC to LA or an LSVC to LA. LSVC is the left superior vena cava connecting directly to LA. So then that can also cause a cyanosis. And again, 2 important points while dealing with cyanosis and heart disease. I would say that cyanotic congenital heart diseases with decreased pulmonary blood flow, that is tetralogy of Fallot and top physiology, which is DORV VSD-PS, TGA VSD-PS, or single ventricle PS. These patients with pulmonary stenosis present more often than not with visible impressive cyanosis. But on the other hand, cyanotic congenital heart disease patients with increased pulmonary blood flow, like TGA VSD without PS, DORB VSD, no PS, single ventricle without PS, or even TAPVC without obstruction, sometimes these patients might have a saturation between 85 and 95, and it might not be very impressive clinically. So that is why it is extremely important to check SpO2 in all patients if you want to rule out heart disease. So that's all for today. We have come to the end of the talk. Thank you all for your patient listening. I think we can now open for questions.
ക്വസ്റ്റ്യൻ ചോദിക്കുന്ന ആൾക്കാരെ അൺമ്യൂട്ട് ചെയ്തിട്ട് ഒന്ന് ക്വസ്റ്റ്യൻ മേഡത്തോട് ചോദിക്കാവോ?
Thank you for a great talk, Navaneetha. Does anyone have any questions, clarifications? Okay, I think we'll give around 2 to 3 minutes more.
Okay.
Madam, I said you have a question, madam. Please go ahead. Please go ahead with your question.
ഗോപിക SIT-യിൽ എന്തോ ഡൗട്ട് ഉണ്ടെന്ന് പറഞ്ഞു, ഒന്നും കേൾക്കാൻ പറ്റുന്നില്ല.
Hello, good morning, madam. I have a doubt from GMC Kollam. Hello.
ഈ മൈക്രോഫോണിന്റെ അടുത്തോട്ട് വന്നിട്ട് പറയണേ, ശരിക്കും ക്ലിയർ ആവുന്നില്ല.
Hello. Is it audible now? I have a doubt from can you just elaborate why fatigue occurs in an RV outflow tract obstruction?
What syncope in RV outflow tract obstruction?
Like how fatigue occurs in an RV outflow tract obstruction? How exactly why? I mean,
Why?
what? Why? Yeah.
fatigue is a manifestation of inadequate cardiac output.
Okay.
So when somebody exerts, like whatever exertion you do, it demands more cardiac output.
Okay.
So when there is a fixed obstruction, the heart can't pump more blood.
Okay.
Even if it is the right or the left, it is the same, because left pumps straight into the systemic circulation. But at the same time, if the right ventricle can't pump blood into the lungs, it will not come back to the left, right? So,
Okay.
whether there is right or left ventricular outflow tract fixed obstruction where there is inability to pump more, the patients can develop fatigue during exertion.
Okay. Okay. Thank you. Thank you.
Okay.
Hello, can you hear me?
Yeah, go ahead, please.
Yeah, this is from SAT. I'm Dr. Radhika. Thanks, Navaneetha, for that excellent class.
Thank you.
One is in neonates with CCHD decreased flow. Sometimes you have something like increasing cyanosis, but it is not actually a cyanotic spell. So, how can you describe that,
Yeah.
or how early can a cyanotic spell occur in an infant?
Okay. So essentially, 2 to 6 months is a peak age, but it can actually develop at any age, because the mechanisms, as we mentioned, there are 5 or 6 theories which explains why the spells develop. One way in which these neonates can develop worsening cyanosis is the setting of a decreased pulmonary viscosity when the PDA gets smaller. So that is the commonest situation. Like, when the PDA gets smaller or when it closes off, they can develop severe cyanosis. That is the commonest situation. Second, the mechanisms include a vulnerable respiratory center. So some babies have vulnerable respiratory center. They are more predisposed. Other mechanism is like the mechanoreceptor theory. So there are at least 4 or 5 theories, and the correct mechanism which explains all features related to spell. We don't have a theory like that.
So, would you call that a spell? Will that be actually a spell, or is just a deepening cyanosis?
So, if you have to call it a spell, you need to have a sudden increase in the rate and depth of respiration. That hyperpnea is a classical feature of a spell. Simply a deepening cyanosis, like when how the patients collapse or crash when the duct closes in a duct-dependent pulmonary circulation. So that is entirely different from what we would call a spell. A spell is classical, which is precipitated generally by exertion for feeding or crying, or sometimes dehydration. And the classical feature is sudden increase in the rate and depth of respiration. So unless you don't have this, you can't call it a spell.
Okay, thank you. Thank you.
Pleasure. Any other questions?
Good morning, madam. Can you hear me?
Yeah, go ahead, please.
Okay, it was a wonderful presentation. I have one doubt, madam. Actually, what causes this infantile spasm to occur?
What causes?
Infantile spasm to occur.
That is Increase in sympathetic activity.
This activity.
Increase in sympathetic activity. So when the baby cries, feeding its stool, all of these are situations where there is increased sympathetic activity. So that also triggers the inflammatory blood spasm.
Thank you, ma'am.
Get it? Did you get it? Can you hear me?
Yeah, madam. Okay, I got it.
Oh, okay.
Thank you, Dr. Navaneetha, for the excellent presentation of symptomatology. People found it very useful. Thank you very much.
Pleasure then.
If there are no questions, are there any more questions? So, shall we, if there are no further questions, shall we wind up? Amrita?
Thank you all again. Thank you all for listening. Thank you all for
Ma'am.
logging.
Thank you,
all
Veera. Doctors for joining.
Yeah, thank you for me, and I hope you have such interactive classes again. Thank you, Dr. Navaneetha, for excellent lecture today.
I'm going offline.
Abhilash.
Madam.
Yeah. I think we can stop.
Thanks, Abhilash. I'm
Okay,
going
madam.
offline, okay?
ഞാൻ സ്റ്റോപ്പ് ചെയ്തേക്കട്ടെ.
Okay.
ഓക്കെ മാഡം. അങ്ങനെ
Thank you, sir.